I'm Jacob Harris.
And I'm kind of Walsh.
This is Ep.9, and we are following on from our last episode. We are going to be talking about lipids. This podcast is brought to you by PedTest Australia and Bulk Gym Chalk. Connor,
Jacob.
tell me about lipids.
All right. Lipids are quite a fascinating section of the blood work, one that I particularly have a fair bit of interest in. Both in general population and performance-enhancing drug users, this is a very important marker for overall cardiovascular health and risk assessment. Lipids are going to be one of a few main driving factors behind atherosclerosis, which is the buildup of calcium plaque inside your arteries, which causes narrowing of the arteries over time, which can lead to multiple different cardiovascular problems like heart attacks being probably the worst, blood clots, things of that nature.
Just to ask quickly, I just happened to speak to someone recently. They said they'd gone for a calcium test on their heart through an MRI machine.
There's a couple of different ways you can get calcium scores, yes. So,
is that a more efficient way?
I believe the MRI is the most efficient way. You've got there's a calcium scan, which is done it's with the contrast dye. I forget the other one. There's a more basic one. The MRI one is the more comprehensive one that's able to see a clearer picture of the calcium deposits and pick up finer calcium deposits that may be missed on the other scan. Calcium deposits are formed by initially there is some form of damage in the endothelial cells of the artery effectively, and then oxidized LDL via the APOB particle, which is a portion or it's a particle that's attached to LDL, LPA, and VLDL lipoprotein particles. So the ApoB will come attached to the artery along with the LDL. What will then happen is macrophages will notice that there is oxidized LDL that has become bound to the artery wall. They'll come over, they will start engulfing the lipid from the lipoprotein that has become attached to the artery wall, and effectively moving the lipid from the lipoprotein inside the macrophage, which eventually forms a foam cell, which is because they end up looking like white foamy cells. Eventually, at some point, that foam cell will almost die, leaking its contents out, and then we have an immune response that will come along and effectively form plaque over that to stop it, getting back into the system, causing other problems. Over time, you get more calcium that will deposit on the plaque, and then this plaque will get bigger. And what eventually happens is because you've got plaque building up on the inside of the arteries, you get a narrowing of the artery, less blood flow. Obviously, it's going to lead to quite a few different potential cardiovascular complications down the line. Now, within atherosclerosis, LDL, or the ApoB containing particles, is a necessary factor in it occurring. It's not the only factor, so this is one area where carnivores will really push the LDL doesn't matter, which is not true, because if my inflammation's low, my blood glucose is low, there will be no kind of initial trauma that will cause the oxidized LDL to become bound to the artery wall, which is it's so unrealistic. I mean, one thing that people forget is exercising, which is obviously a profound health benefit for us, is an acute trauma.
This podcast is sponsored by Achievement Apex. Achievement Apex creates some of the best barbells in the world, and they supply some of these barbells to some of the strongest powerlifters and athletes in the world. If you want an Achievement Apex barbell, you can go to achievementapex.com and use the code PORTAPOTTY for 10% off any order that you make.
You're causing trauma, you're causing oxidative stress, you're creating a situation, you're creating inflammation, you're creating a situation just through doing something that is long-term healthy, that is now providing potential, beginning blocks of things that the body is seeing as an immune response. Is going to send the foam cells in to clean up the LDL particles or the LPA particles that have become bound to the artery wall and start forming atherosclerosis. One thing with the carnivores that I'll try and point out is that LDL being high is not a problem, because without some form of inflammation or initial damage to the endothelial cell, it's not going to become bound and then begin forming a calcium plaque. This just isn't true, because there's always going to be situations that we are subject to, such as exercise, which is going to create inflammation and oxidative stress, and then things that are potentially able to cause that initial trauma that then begins the formation of a calcium plaque buildup. Without excessive amounts of ApoB containing particles, which are all of your LDL or low density lipoproteins, all of your VLDL or very low density lipoproteins, and all of your lipoprotein A's, or technically lipoprotein little a. So these are your main atherosclerogenic ApoB containing particles that are the ones that are going to become initially stuck to the artery that then forms a foam cell. Without excess amounts of these, we just don't really see excessive amounts of calcium buildup in people's arteries. If we were able to completely remove ApoB, we wouldn't see any formation of atherosclerosis. And this is kind of seen even in humans to some degree. When we're born, we have almost no ApoB, or the lowest ApoB containing levels that we have in our entire life, and we see completely clear vascular structures, no calcium buildup, no nothing like that. So yeah, look, it's statistically, cardiovascular disease is what's going to kill all of us. I think it still accounts for about 70% of all-cause mortality.
In reference to, like, are we talking things like, I mean, obviously we're talking many things, but we're not just talking about heart attacks, right? Like, what are we? Is it just heart failure in general?
Just generalized cardiovascular events. So what accounts for?
So people dying in their sleep and dying in hospital and stuff. They're just from things like heart failure, or like it's not necessarily, because we think cardiovascular problems. I think a lot of people's brain just goes
straight
to
a heart attack.
Yeah.
And heart attack is still one of the most prevalent causes of death.
An interesting thing, because Connor's the information guy. But I did look this up, and it's definitely fully sourced from the third page that I clicked on Google. But apparently, someone has a heart attack every 80 minutes, which is pretty interesting. I mean, that's universal. But that's crazy to think about that. That in less than every hour and a half, someone's having a heart attack, and not necessarily dying from them.
Yeah. Honestly, I thought it would have been even more frequently than that. Was that like in Australia, or is that a worldwide statistic?
I did not check.
Okay.
So you can quote me on that.
Yeah.
Because I'm quoting something I'm not even sure about. But I found that interesting because I was curious myself. As we know, people have heart attacks. They are regular.
Yeah.
And what do they always say? I think some people used to say that sort of shit with sharks and lightning strikes, or you're more likely to have a heart attack than get attacked by a shark, or any of these things that people try to compare. So we say stuff like that all the time, but I was actually genuinely curious as to how common they are. But then when you talk about a lot of things that you're talking about, it's not a surprise that they're as common as they are. This podcast is sponsored by PedTest Australia. If you plan on using or are currently using performance-enhancing drugs, it is very important that you make sure you are doing so, having them been tested before you use them or while you are using them, to make sure that you take care of your health. And you can also recommend that the people around you do so as well. Go to PedTest Australia on Instagram to find out more about the details on how you can test your current performance-enhancing drugs that you are using, or you can find out more about testing other compounds or things that you are putting in your body if you would like to make sure that you take care of your health.
They're very common, and unfortunately, the first known side effect of a heart attack is death. Well, the most common first side effect of a heart attack is death. So this is something that you certainly want to be taking seriously. I mean, cardiovascular markers as a whole are extremely important. Lipids are one thing that we have a lot of control over, whether that be through diet and exercise intervention, and even pharmaceutical interventions are extremely good for managing lipid profiles now.
So can we move on to, am I doing all right? Or
yes. I mean,
okay.
You're doing well. You're doing
good.
well. Now, the way I look at lipid profiles are going to be slightly different for enhanced versus non-enhanced athletes. Jacob obviously being on Team Natty Crew. You're going to see with enhanced people almost always, especially at super physiological doses, a reduction in HDL cholesterol. Currently, where the literature stands, there's a lot less involvement in HDL cholesterol with mortality and increased mortality risk when levels are low, as opposed to high LDL levels. So I'm honestly a lot less concerned about the HDL marker than I used to be. especially in the enhanced side of things. If you were extremely low as a natty for no reason, then may be worth looking into further. But I'm more concerned with LDL and in particular actually ApoB, which we'll go into in a little bit. But your LDL is good. Your most recent one was a 2.6. Completely fine with where your HDL is. If you were enhanced with a lower HDL level, I would like to see that probably below about a 2.2 generally. Triglycerides at a 0.7, that's perfect. Minimal free-floating fat around the blood, which in excess amounts can cause things like insulin resistance and contribute to other cardiovascular diseases. Total cholesterol is, again, not something I'm overly concerned about. It's more comes down to kind of your ApoB containing particles, which are the cholesterols, which, as I mentioned prior, which have the protein or the particle bound to them, which allows them to become bound to the artery wall. Without that, they do not come bound to the artery wall. So they're, not a problem as it pertains to atherosclerotic risk. Now, the thing with ApoB is most doctors don't actually test for it, especially in Australia. It's something that you'll have to specifically ask for, and you will also have to pay for out of pocket. So LDL, which is what is typically tested by your doctor, compromises the majority of ApoB containing particles. But within ApoB containing particles, you've also got the VLDL portion and then your lipoprotein A portion. Lipoprotein A is something that is currently not really able to be modified through lifestyle, diet, factors, stuff like that. Even pharmacology is very close to ineffective as it stands with what's actually human approved for lipoprotein A or higher lipoprotein A use. There are drugs like PCSK9 inhibitors, such as Repatha, which offer a modest, I think around about 20% decrease in lipoprotein A levels, which is not overly significant in the case of the people that are after the treatment with severe elevations of lipoprotein A. There are some other drugs that are currently in, I think, phase 2 or 3 human trials, which have been highly efficacious in showing, I think, between 70 and 90% reduction in lipoprotein A levels. But because we currently don't have any approved way of changing lipoprotein A levels, it is effectively a test that you only have to do once because it's almost entirely genetically determined. So you either have high lipoprotein A or you don't, or you're somewhere in the spectrum. It's not something that's going to really change throughout your life unless we have access to these kind of new drugs that are currently in testing, which allow us to change that. So lipoprotein A is a portion of your lipid panel that I would suggest everyone gets tested at least once. Once you've been tested, obviously, because you have very little control over changing that marker, it's not something you really need to follow up on, unless obviously you're in that camp, and it's not overly common. But if you are in that camp of a really high lipoprotein A level, it may be worth looking into some of the pharmaceutical interventions. But more than anything, it's just a good risk factor to kind of see where, or one of your genetic areas as to whether you kind of have a higher predisposition to stuff like atherosclerosis, because the lipoprotein A is extraordinarily atherosclerotic and actually has an independent risk factor for atherosclerosis outside of ApoB containing particles. So that having high lipoprotein A, even if you were able to have normal ApoB, is still an independent increased risk of cardiovascular disease and mortality. The ApoB reading is obviously, as I mentioned before, that's one that you would have to ask your doctor for. It's not commonly tested for, but it's really a more rounded result of all of the kind of damaging or the potentially dangerous, because that cholesterol and lipoproteins obviously have an important function. They're not bad per se. There's no such thing as good or bad cholesterol.
This podcast is sponsored by Bulk Gym Chalk. Do you struggle to hold onto your deadlifts? If so, it can be very important to make sure that you have good quality chalk and access to that chalk. So go to Bulk Gym Chalk. You can find them on Instagram and get yourself some good quality chalk so that you can make sure that you can train in the gym and get the best out of your training while doing so.
But there are ranges that you want to maintain to kind of minimize certain risks, still allow bodily functions to occur, but limiting the exposure to things such as, excessive ApoB containing particles, which then, is going to kind of lead to foam cell formation and atherosclerotic plaque buildup. So
in terms of everything that we've looked at here, bar the fact that we don't have that
Yeah.
marker, I'm all good.
Yeah, you're all good.
That's all I care about. Other people as well, obviously, but mainly me.
Yeah. So
Yeah.
everything here, obviously, as we've mentioned, we don't have the LPA or the APOB. So this is just a standard lipid panel that we've got here for Jacob. Everything's fine. It's good. I imagine that APOB would most likely be okay based off the LDL level, just based on the fact that obviously LDL is still the largest sum, or the largest amount, makes up the largest amount of APOB containing particles. But to get a better picture, if we added an APOB and an LPA to this, we'd have a pretty full, comprehensive understanding of what Jacob's current lipid panel would look like.
And understanding, like you said, the other marker you were just referring to.
LPA, lipoprotein, APOB.
No, the one we don't have.
APOB.
APOB, yeah.
Yep.
So given that we can't really change that, the impact on these ones would be cholesterol, so possibly like dietary related cholesterol, and as you said, things like exercise and stuff. If you were like, say your lipids, in the ones that we can see aren't great,
Yeah.
the way that we would improve them. So this would be
Yeah.
this could possibly, what we're looking at here would possibly be the indication that I am not consuming like vast amounts of cholesterol, like let's say I'm not eating 10 steaks a day, because those numbers might be different.
Yep.
And you can see I'm obviously exercising to an extent. So diet and exercise is a somewhat of this is somewhat a reflection of that.
So for all ApoB containing particles other than LPA, lifestyle and diet factors are quite strong influences on the level. So yeah, the fact that you don't have excessively elevated LDL also partially is genetic as well. It's a big part of it. Some people just have completely different cholesterol metabolism. Some people, like myself included, I can eat, and I've done blood work on this, so carnivores don't come at me. I can eat a shitload of saturated fat, and my blood work doesn't change whatsoever in terms of lipid panels. I just am able to metabolize it in a way that it just doesn't lead to any increase in LDL levels in me personally. There are lots of different genetic subsets of people and how they metabolize cholesterol that gives a very large spectrum on the way people react to that. You get other people that you put on a high saturated fat diet, and this makes up the majority, and you will start to see things like LDL and ApoB go up very quickly. Also can be a marker for just overall kind of health and body fat as well. Especially the triglycerides. If you're starting to see triglycerides go up, there can be a few other things potentially. Non-alcoholic fatty liver can be one that may be having some interplay with triglyceride levels. Diabetics also tend to have elevated triglyceride levels as a result of also the elevated blood glucose levels and not being able to kind of remove substrate from the blood effectively.
Because you'd mentioned that you had your lipids here as well.
Yep.
And you wanted to kind of use them as not a reference point, but to not compare even, but really just kind of put more perspective on the differences possibly.
Yeah, look, so I have a set of my blood work here as well, which just has the additional lipoprotein A and ApoB marker. I've just got effectively, this is just the page of one of my lipid panels with some of the additional markers on it, such as lipoprotein A. One thing I will just say for a lot of people, because I've actually had clients nearly order the wrong test when I've asked them to get this done, is there is a difference between lipoprotein big A and lipoprotein little a. The one that we're wanting to test is lipoprotein little a, or LP bracket little a. The lipoprotein A1 you'll usually see tested with ApoB as a ratio. I really don't concern myself with lipoprotein A1 numbers at all. It's really just the lipoprotein little a and the ApoB that I look at. So here I've got one of my blood tests. For me, this is one of the reasons why I'm able to kind of deal with the cardiovascular sides and just general health sides of anabolic steroids better than most. My lipoprotein A is effectively untraceable, which is really where it should be for most people. It should be very, very low levels. But so I kind of come back as low as the blood test parameters pick up. And then as far as ApoB, I also sit below the normal reference range, which I will preface by saying the reference range is probably not very good and could probably do with being a little bit lower to begin with. But yeah, this set of blood work here was done, I think, about 2 or 3 days post States last year, so coming off a pretty heavy anabolic cycle. And this is about as high as my APOB will ever get, and it was 0.61 with a reference range of 0.7 to 1.3. So total APOB levels are, and this is me on peak blast on multiple grams of anabolic steroids, orals, everything that you're kind of using into a comp. I had a 0.61 APOB, so fairly low. I would still love to see it lower, but in terms of what is currently classed as kind of the gold standard for health, well, not the gold standard, but what they consider that the healthy norm for APOB is, I'm well below that. So my total cholesterol, my LDL cholesterol normally sits between about a 1.8 and a 2.2, just to put in reference to kind of where your LDL is sitting, which is a 2.6.
This podcast is sponsored by Power Pit Rockingham, and Power Pit Rockingham is probably the best gym for you to train in if you are in Rockingham and want access to quality powerlifting equipment and a good environment to train in when it comes to powerlifting training or bodybuilding training. If you are in the area and want to do so, pop on down to Power Pit Rockingham, jump in for a casual session and tell them that the Porta Potty sent you.
My HDL, however, will range from anywhere from about a 0.6 to a 1. Where you are sitting at a 1.6. So for me, if I'm on blast, using a decent amount of anabolic steroids, especially orals, we'll see that, drop down towards the low range, towards about a 0.6. And then when I'm cruising, usually a 0.9 or a 1, depending on kind of what we're calling a cruise. But very rarely will I ever see my HDL above a 1. In fact, I don't reckon I've seen my HDL above a 1 probably a decade. But they're the kind of, the HDL is going to be the main difference that you're going to see in kind of anabolic steroid users versus non-anabolic steroid users, lipid panels, as well as a bit more of a prevalence for high LDL and ApoB in your anabolic steroid users, just because of some of the changes they have on lipid metabolism as well.
Interesting. Well, for the most part, man, I feel like you've made it easy to understand why there's why there should be a significant focus on lipids in general. And obviously the two main ones, or the ones that you can control, being diet and exercise, is kind of what we're doing here, right? I mean,
for sure.
For the most part, we're doing, even towards the end of the cut, which is when I did these, there was some regular cardio just daily, even steady state. Wasn't doing any high intensity stuff. And you much steady state yourself?
Yeah, well, currently I do a ton of steady state. I do like to incorporate some steady state in most clients. Obviously, take into consideration fatigue, allotment and whatnot for clients in prep, but I do try to keep a baseline of cardio in for health benefits, to keep heart rate down, improve lipid metabolism, just general health benefits, really. It's
what would you put in as an average? Mine's always, or whether it's a client or even myself, I kind of think the 100-minute a week mark is kind of where I like to be for averageness.
Yeah, look, if someone's not in prep, so let's look at this from a kind of a powerlifter point of view. How I usually would structure a powerlifter would be off season, normally one HIIT cardio session, and then 2 to 3 low intensity steady state cardio sessions, depending on that person's kind of workload, steps, and then also their requirement and how much they need to bring up the cardiovascular capacity. If they're really out of shape, we might even try to push it to 2. And then as fatigue requirement from training comes up, so say the client starts moving into a prep for a competition, and obviously priority now becomes the strength peaking side of things. That's when I'm going to pull back the fatiguing cardio, like your high intensity interval stuff, and just keep a baseline of low intensity steady state in there. Generally zone 2 is what I like for the low intensity steady state session. So that's normally for most people about 115 or 135 beats per minute heart rate. Minimally fatiguing. Technically, it's kind of in your fat burning zone, which I know there are studies that go against it in terms of body composition, but I do think, especially when polypharmacy comes into that, the fat burning zone with cardio does have benefits on body composition as well. But we can talk about that in another episode possibly. But yeah, it's really going to come down to the individual and their requirements, kind of what their sport sits at. If you're a labourer that's doing 15,000 steps a day, you probably don't need to be doing a ton of extra low intensity steady state, because that's what your job is. If you're still lacking cardiovascular capacity, you're probably someone who needs to focus more on a bit of high intensity interval training stuff, because you're already getting a fair amount of that kind of steady state cardiovascular activity just through day-to-day movement.
Mm-hmm. Yeah, I agree, man. Like I said, there's like an average level that you take with everybody else. I often say to people that, to be honest with you, 3 30-minute sessions of something like that a week is like enough for like the general population, because most people aren't getting any in.
Yeah, for sure.
There's thousands, hundreds of thousands, millions of people that aren't doing any. So acting as if we need a certain amount per week and stuff is ridiculous. I just think if people kind of are doing a decent, regular amount of anything, as you said, like if someone's working a job like that, that's probably why we have so many people getting away with it, really, because they actually are doing it. They're just not doing anything outside of that.
I mean, like, I could tell you massively my cardio requirements changed from being full-time car detailer to being an online coach who sits on their ass on a computer all day.
Just for the record, we don't all sit on our ass, just Connor.
Just me, all day.
I'm really busy actually doing many other things, like editing on my couch, which I'm actually probably laying down doing, so it's probably burning even less calories.
Yeah.
But yeah, look, man, I like that we were able to cover that a bit more extensively, because as you said, it's not really a small topic. And yeah, I found it interesting.
There's still definitely even more that we could dive into this. If people really want to go deep into the weeds with it, possibly let us know in the comments. But yeah.
Absolutely. As usual, I'm Jacob Harris.
I'm Connor Walsh.
That has been episode 9. Thank you for listening.